So hello everyone. So I hope you can hear me very well. So this is Dr. Shahriar. We're going to start today's session, and I hope you can hear me well. And taking this class from our studio actually, and I hope you are in good health. And this will be a 5 months journey. And I just shared my class routine actually, and we're going to start the video session shortly. This is a full MC course, and usually we conduct courses 5 months. We do have MC clinical version as well. We do have the MC MCQ version, and I wish you all the best with this 5 months journey with us. I'm sure it will be a great experience for all of you to conquer this exam. Actually, it's a exam based on MC part 1 and the part 2. And if you are new here, please check out this particular website, which is like the main website for AMC, www.amc.org.au. You'll find most of the information. Some doctor also messages, doctor, is our medical college is recognized? You can also check your medical college eligibility there, or you can, if you don't find it, you can inbox us actually to check those kind of things. I mean, again, just double check these things. Is my voice and everything is clear? It's supposed to be clear actually. Yes. Yeah, I think it's clear actually. I mean, maybe the other doctor. Okay. If voice is not clear, in that case, let me double check. If you're using a mobile device, I cannot be sure, but I just want to, yeah, I think it's clear, I think. Yeah, I think voice is fine. Because it should be either very fine or it should not be totally not fine, I think. So those with mobile and not using headphone, try use a laptop. All right, I think it's clear. Yeah. No worries, because if sound is problem, everyone will have the problem immediately. Yeah, so I think it's not a problem. Yet we always recommend to use a laptop. I'll tell you why in future actually, but emergency cases you can use a tab or a mobile. As you all can see, this exam is based on MC part 1 and the MC part 2. There's a very big thing, for many people ask me this thing, doctor, is it really possible to get a job after MC part 1? The answer is yes, but there's certain condition applied, which over the time will tell you all actually. I mean, which of you are eligible for a job after MC part 1 exam. Actually, for that, you have to be with us in the coming session. And today is a one session, and on 18th there will be another session. Actually, I think in 18th I will be clarifying more about that one. Who is eligible more after MC part 1 to get a job. Actually, technically everyone is eligible, but not everyone's CV is up to the mark to get that particular job. Actually, great. A few of things, and we move forward. Yes, we do have a very big number have passed. I think I need to update that one. It's 1,900 if we add our recent November. I think a huge number has passed already. Great. And yes, so we are doing Zoom, and we will take live classes as you all are doing the live classes. And we usually take 2 classes, and it's usually 3 hour classes, long classes. Now, some doctor asked me, doctor, why so long classes? Why not you divide that one into 3, 4 classes? It's because the exam is long, almost 3.5 hours. So it's like a military training, it's kind of, whenever you are attending these classes. Good news, whenever we take class, the immediate next day we upload the recording. So in case if you miss the class, it's like not a problem. But if your schedule, I'm telling it again, very important, please listen this part carefully. If you know that every Sunday, Thursday, you have a job, you are not, in that case, I think suitable for the live courses. In that case, we have a special packages available, like which is more like a Netflix type package, because if you can't come to the live classes, it's not very worth it actually attending this batch. So we have a two type of version of batches. One, this one, and in these batches we also do upload recording, but for some time being. But in there is a group which is like a full 1 year access. They just keep checking things, and the videos get updated actually with the time actually. So whoever suitable for which kind of batches, I think you can message us in that case. Maybe tomorrow in that case. Today is a very busy day for us actually. Okay, but I personally recommend always live batches if that is possible. But if you're a busy practitioner and if you can't attend live in any way, every week, if you have chances to miss 1 or 2 classes, then I think this batch is not suitable. You were recommended for Netflix type of batches actually. Right. And of course, we'll give you weekly mocks, so please be very attentive with us. So that's why the reason is actually because if we are not taking mocks classes, we can course you out actually in that case from the live courses after 1 month actually. All right. So coming with this one, it's a good course, I think, believe me. And it's a course, not a course, it's a hope actually, because we know at least a huge number of doctors are already working in Australia actually. All right, great. We do have, 3 months courses as available as well, actually. Okay, we have a very large community. Share your AMC guideline. I hope you are added to that one already, actually. And this is the WhatsApp. You can WhatsApp me regarding your feedback in the course, or if you have some inquiry, you can also message me in the Facebook as well at the same time. All right. So that's really wonderful. And I hope you are connected to my YouTube channel. There's so many, almost, I think, more than 200 video I posted since last 8, 9 years regarding the AMC, like uh, frequently asked questions. Many of you probably joined because you used to see some of the videos. We posted some of the previous classes, how to apply for a job, how about there is a clinical gap, so I mean, so many variety, and also there's a lot of pathway, throughout. We'll be also yeah, I mean, everything is available, but we'll talk about that one not in today, about the recorded course actually. It's not the time, it's just only focusing on the live today actually. Great. Great. So that is the thing actually. I mean, how recorded things looks like, that will be kind of like that actually. Yeah, same class would be there actually. For example, they can also see that recorded version actually. But today's not the time to discuss about those things. So no message for at least at this point in the Zoom chat box regarding the recorded courses actually. All right. Now, very important, if you haven't subscribed to my YouTube channel, very important, because sometimes few things we cannot tell in classes actually. I mean, it's not related to academic, but some things related to your job, something related to pathway. In different classes, I try to talk about few things actually. All right. So, but when we make separate videos for the YouTube, which are little different, especially in terms of uh, clearing a lot of your confusions actually, so please check out if you haven't subscribed. Yes, so it will be fine in that case actually. All right. Is my voice is okay? Again, I'm double checking. Is the voice is okay? For me, I think looks fine from this side. Double checking. Yeah, I think it's clear. I think. Yes. Yeah. Yeah, it's good. Mm. Okay, let me do a little experiment with the sound. If you just still, because I'm using microphone Realtek. Yeah, that looks okay.
How about no? Yeah, yeah, ear code, is not recommended. Yes. Testing, testing. Microphone. One, two, three, four. Testing microphone. One, two, three, four. Even more better. Yes. Okay. Yeah, there's two, three modes. Yes, much better. Thank you, everyone. All right. Can we go to the class routine, guys? I mean, just giving you a little idea. Can we go to the class routine so that I can tell you about the syllabus and this, that actually. Um, okay, not this one. Okay, so we are here, first of all, 2025-26 routine. Please confirm you can see the routine well. Please confirm me if you can see the routine well. That is wonderful. So, usually we start with the medicine. You see, medicine is almost like 30% of the syllabus. So, the medicine started today. We'll take the respiratory session. Then followed by there will be GIT, cardiology. We didn't separately went for the overview. Normally, overview means which we usually upload on the Fridays actually. Usually it's not a live. So Friday we upload something which give you guys idea that what are the topic I'm going to like tell you or teach you in the classes. It's like some people wants to know that, okay, doctor, I mean, what things I want to prepare. There are two group of doctors, like, one they want to prepare early, one they listen to the video and then they start. So the overview thing usually it's like a giving you an idea actually. Yes. All right. So yeah, in the same batch 65 group. Everything will be through the batch 65 group. I'm sure the group you were added, where do you find the Zoom link, right? Great. Coming to this one. By the way, today will be like respiratory. I mean, we're getting into respiratory in next 5 minutes. So medicine, respiratory, GIT, then there'll be cardio. Cardio, we have see normally one extra class than usual, then renal, rheumato, and all these things. And then the neurology will finish the uh, this particular classes. Nero will try to add one more extra classes for you guys. Okay, pediatrics, you can see this pediatrics, this thing, including there's a special video on immunization. So there's a theory recall based things, and of course, then there will be surgery, which includes general surgery, then emergency. Then comes the special things like ortho, eye, ENT. These are very important. So as you see, we try to cover almost everything. Then comes few things like, like something maybe some of you don't like, and also some cases I also don't like, this gynae ops. So gynae and the ops, this is important. Equally important, we all are not be here today if there is no such gynae ops doctors in this world actually. So it's a that way gynae ops is important. Okay. So, and psychiatry is like, so multiple theories followed by there'll be recalls and this, that. By the way, guys, I mean, after 2, 3 subjects, I will also give you guys question banks actually. So you don't have to buy question banks separately. Uh, what you need to emphasize more in the class theory classes, then the next week we have a recall class. In the recall classes, we'll be posting a file regarding the recall which you can download later. That's how it works actually for us actually. All right. So yeah, so these are the thing, and later there will be some special videos which we will find where I will tell you that one. And usually we take mocks every week. Other than there will be some computerized mock later at the end actually, which will be same as the AMC screens actually. Okay, so this is the in general syllabus, and after the psychiatry, we finish usually with ethics with some miscellaneous things actually. Okay, did you get an idea about the syllabus? General idea, because we want to get into the discussions now. We want to get into the discussions. Not following the some of the things because we want to get into the classes as soon as possible. Actually, I will tell you time to time what is needed. Okay, you need to trust the like most experienced mentor. So I'll tell you everything where needed. I will tell you that actually. So 4 pillars here: theory, recall, question bank, mocks. Okay, so this is how you need to speed up. This is how you need to follow. All right. So yes, topic wise, if you go, you will have a solid base actually. We'll have a lot of discussion in future, guys. I mean, how about we, get into John Murtagh today actually? Will it be better? I think if we get into our um, respiratory system, what do you think? Yes, I think that's better. So I want you guys to open up. I'll try to help you guys here actually. So asthma, and you can see some of the page number 866 for the ninth edition. 866 for the ninth edition actually. I'll be taking down the screen just for a second so that simultaneously I can add few of the things from the eighth edition to guide you because it's early, but I want all of you to buy uh, the ninth edition. So 868 is the for the eighth edition page actually. Okay, I'm sharing the screen. I'll be trying to use the boards in for initial few days actually. Okay. We're using the John Murtagh. Someone asked which book. My dear, it's the John Murtagh ninth edition. It is absolutely important. This is highly recommended book for study. Okay, so we are here. Yeah. So this is that ninth edition actually. This is that ninth edition in Interested actually. Now, certain important thing about the asthma. Asthma, good news is, it's a whole chapter is given actually, but normally John Murtagh, different things are given in a different place. So which I will guide you guys in the classes actually. Apart from that one, we do have a SMA note, which I will also show you time to time during the classes actually. So while you study the theory, you make a combination of John Murtagh and you make a combination of the SMA AMC note actually. So both of them together, you make a blend and a combination. It will be really nice actually. John Murtagh 9th edition, you need to buy hard copies actually. Great. Now, coming to this particular point, so for asthma, few important things, but we'll get into the chapter risk factors, management, exercise-induced asthma, step-up management, SCD fluticasm, and the differentiation with the COPD. Often questions are given asthma versus COPD. Think guys, fully focus on the class now. No need to write anything in the chat. Let's get into the full lecture now. Actually, now coming to this particular part, I mentioned the risk factors are important. So 866 is the page number for the ninth. Now, here is a risk factor. And before that, what type of disease is asthma? Just in a 30-second, I'm going to mention. It's a chronic disease. I mean, I'm using few words. It's a chronic disease. It's a multi-system, not really multi-system. It's, I think, more confined to the respiratory system. If you say sarcoidosis, which is more like a multi-system. So it's a respiratory disease, not really a multi-system disease. So it's a common disease. It's a chronic disease. It's a reversible disease. It's an inflammatory disease, right? So these are few words you can use for the asthma. Especially, I want you to remember the word reversible and the chronic. Okay, these are the two things because we will use these two words later actually. And this particular condition is usually associated with wheeze, cough, the chest tightness and the breathlessness. These are the classic four symptoms for any asthma. There's more other things which we called atopy. Someone is having different kind of allergy. Sometimes we make fun. Allergies are like brothers. Allergies are like bhai. Sometimes we mention like that actually. Okay, so it's more over like a atopy. If it usually runs in the family, and so many type of allergies. Asthma is also inflammatory and allergic condition at the same time. Right. I hope that's cleared the basic part. Now we get into the important part, which is the risk factor of asthma. In terms of the risk factor of asthma, there's so many risk factors are given, especially cold, dust. These are very important contributing factor. We also take history if someone is taking any new drugs actually. So drug-induced things are important. Some drugs are given here. You can see. I mean, I'm sure you read it in MBBS level as well. So you can just mark it while I'm telling. So mark these particular areas can be very important. Among the drugs, you need to know like what are the drugs that can cause asthma. Any drug that can cause bronchodilation actually can cause asthma. That's the basic, even which includes painkiller, beta blocker, many other similar drugs. Now, important for exam, which has been tested uh, already and repeated a couple of times. They mix up something with AC inhibitor. They mix up something with the AC inhibitor. Now, see, people have asthma and people also over the time develops hypertension. Now, is it recommended you recommend him ACE inhibitor? Now, think and answer now. Like, do you recommend the person ACE inhibitor actually? Now, uh, the answer is here. Uh, Guys, this kind of question you can answer as a yes or no. So AC inhibitor recommended in asthma cases, answer as a yes or no. Answer, it is a no because AC inhibitor, exacerbate cough, and when we cough, we cannot breathe properly. Okay, so it introduces cough, yes, and you cannot breathe properly in that case actually. So instead, the recommendation is ARB, right? So instead, we recommend ARB. This is an important question. Is an important question. Yes, it's because of bradykinin. Yes, you are absolutely right. Right. Occupation thing, my dear doctors, like when we see, because it's an MCQ based exam, I'm sure you must be knowing, in 3.5 hours, you have to answer, it's like a 150 questions, right? So basically for one question, it's like a 1 minute or a little bit more actually, right? So you have to be very careful in the exam. Great. So this is the important line, and occupation is very important because the question starts with say a 50-year man, having this problem and the previously known case of asthma and his job is related to like a chef or something. So someone is using wood, someone using in a industry dusty. This can be an aggravation of asthma. It can be aggravation of asthma. Initially, it can be, say, someone is working in a industry, in a factory, like I say, jute factory, chemical factory. They can develop definitely asthma over the time, actually. Initially, it can be occasional and then it becomes more chronic and more continuous, actually. Okay. Moving to the next, and now we can see bronchoconstriction is the key. You can see a lot of things are accumulating like infection, inflammation, so eventually it gives rise to dyspnea. Actually, that's the short pathophysiology. These are the four classic symptoms. Like wheeze, we all know is the main symptom. Wheeze is nothing but a musical sound. When we put the stetho, we call it rhonchi. That's the only difference. Okay, moving forward to this part. Yeah. So in a asthma chapter, all right. Yeah, few things will look quite similar, so don't worry. Did you know? I mean, I asked you to remember one particular point, which is something called reversibility. Now, is there any way we can uh, somehow do a test to rule out asthma? Now, there's so many tests, like allergic test, then spirometry test, blick flow test. Even we do X-ray, even though it's not a essential, but definitely why we do it, because to rule out other conditions like pneumonia, other conditions like pneumothorax, it's absolutely important to rule it out. Okay, so initially we do the spirometry, and there is a thing called FEV1 by FVC. If it is less than 75%, we think this thing as a obstructive lung disease. So this brings us to a very important point. This brings us to the a very important point. Obstructive lung disease. Are you familiar with obstructive and restrictive lung diseases, everyone? Are you familiar with this particular things, obstructive and restrictive? Okay, give me some example of obstructive and restrictive lung diseases, my dear doctors. Give me some example of obstructive and restrictive lung diseases. All right. Okay. Speaking about obstructive versus restrictive. Okay. I remember very well about obstructive lung disease as ABC. A for asthma, B for bronchiectasis, and the C for, COPD. A classic FEV1 by FVC, by spirometry when we do, the reading would be less than 75%. Do you know this interpretation? That this is like a confirmatory test. Can we say this is like a confirmatory for obstructive cases? Yes, it is. So spirometry is like a confirmatory for all obstructive cases. Normally we say it is for asthma, it's always not like that. So it is for generally obstructive restrictive lung disease. It is the spirometry, which includes FEV1 by FVC. Same interpretation for restrictive lung disease cases. What would be the interpretation, guys? In FEV1 by FVC cases, any idea, any cases? FEV1 by FVC in restrictive cases, any idea? It would be 75% or more. So normal or raised. Normal or raised. So this is the biggest difference. This is the biggest difference. So can we add to this? What will happen to the residual volume in obstructive lung disease? Now this brings us to the important point. Residual volume. Actually, this is very important parameter. So residual volume, do you think will increase? What do you think? Yes, so residual volume will increase here. If residual volume is increasing, what happened to total lung capacity? I'm going to do a little physiology right now. So total lung capacity also increase. The same thing, this parameter, residual volume decrease, which also brings us to the point. Total lung capacity also decreased actually. Okay, this is very, very important things to rule out obstructive and the restrictive things actually. Most of the restrictive lung diseases, if you see some of the um, fibrosis features are there. Have you noticed this lung is more like a diseased lung, kind of like a in a funny way, like important lung. It does not have much capacity. It's more like that in restrictive lung disease, which includes fibrosis, interstitial lung disease, pneumoconiosis, all occupational lung diseases, sarcoidosis. Okay, so all these things, you see, the lung is functionally not much active actually. It lost almost its capacity. So this brings us to the point that restrictive cases, is it possible to see crackles? Okay, is it possible to see some sort of like crackles in some of the restrictive cases, isn't it? And in obstructive cases, can we say because the air is coming out, through a musical area, so it's more like producing a musical sound, so which we are calling as a wheeze or a bronchi. So can you understand? Do you understand those basic differences? Yeah. Wheeze as a musical sound in case of obstructive lung disease. Restrictive lung disease lost its capacity. Generally, it's like poor lung quotation. So the capacities are gone. So in that case, you get to see few abnormalities like crackle sort of sounds actually. Okay, so crackle type of sound, inspiratory crackle, like this kind of inspiratory crackle, and in asthma, COPD, these particular cases, like more problem in releasing and this thing. So it's like expirational. Okay, so in uh, this restrictive cases, it's like inspiratory crackles are more, whereas in uh, this obstructive cases like expiratory. Okay, I'm going through a little detailing now, which maybe some of you may not be familiar, so please take note. So expiratory things are more involved in obstructive. Inspiratory things are more because it's generally lost its capacity. So it doesn't matter inspiratory, expiratory. So it can be both inspiratory, expiratory more in the restrictive, but more better to or easy to say inspiratory crackle. Whereas inspiratory things are less common in obstructive lung disease. I hope that's clear. If not clear, at least write it down. You can do your research a little later. Now, this brings us to the point actually. Obstructive lung disease, again, of three different types, right? I mean, I already mentioned it's like asthma, bronchiectasis, and the COPD. Asthma and COPD is a big differentiating disease. Now, how can I differentiate asthma and the COPD in the exam question or in a real life? Any idea, any cases? Okay, I will get into the clinical one later. I mean, because we have a separate chapter on the COPD. But speaking about these clinical things, actually, yeah, like forget about age, smoking, and many other things. How can we differentiate investigation wise? Now, if you remember, I asked you something or for you guys to remember reversibility, that particular word. There's a thing called reversibility test. We call it reversibility test, actually. Reversibility test, what happens? Anyone knows interpretation, or do you want me to explain the reversibility test interpretation? Please comment as a yes. What particular drug we use here? We use bronchodilator as a SABA as a test. Okay. Now, normally the interpretation is like below 75%. Example, in a asthma case, I repeat, in a asthma case, let's say you do spirometry, it comes around 60%. I'm just giving an example. A COPD case, that interpretation also comes around 60%. I mean, if you V1 by FBC, both cases, 60%. Now, as a bronchodilator test or reversibility test, I keep, spraying that bronchodilators to see how much the lung dilates. What would be the interpretation in case of asthma after 30 minutes? After 30 minutes, what's your expectation? I'm expecting it will be at least 75%, whereas in COPD, it will be kind of like 63%. Now, why? Now the game begins actually. I did reversibility test with a post, or you can say post bronchodilator after doing spirometry. 60% asthma shifted to 75%, which is like a 15% deviation. Now, did you read anything in Davidson Medicine or any relevant book that there is like a 15% or a 12% deviation is recommended? Like according to Davidson, I think it's 15% says. So 15% if there is a deviation or improvement, better word, improvement, is that indication of asthma? Now, why is this 15% improvement? I want your explanation in next 15 seconds. Why you are expecting 15% improvement in asthma? Answer is very simple. Asthma is a reversible condition. It depends on the bronchus dilates or constricts. Now, when it comes with the COPD, I haven't taught you COPD yet, but you must be knowing about COPD. Is it a reversible disease or is it a permanent or a irreversible disease? If you go deep down in your MBBS knowledge, maybe you can find it out. So COPD is an irreversible chronic and irreversible condition. Permanent, abnormal and permanent dilatation of the bronchi and bronchial. Remember the definition? Abnormal and permanent dilatation of the bronchi and bronchioles. Abnormal and permanent. So nothing, no matter how much bronchodilator you give, it's not going to change much. So that's why the deviation only will be very less, like 3%, 4%, not 15%. Is it clear to everyone about the reversibility? Asthma is a reversible condition. That's why reversibility 15% positive. COPD, on the other hand, is an irreversible condition. So you are not getting 15%. I hope that's clear. Okay. This is the method we use for spirometry things, actually, which I think for many doctor it was not clear before, right? I hope it's clear now. If you research it a little bit, it's a very good concept. And it is also given in the exam very often, actually, at the same time. Now, coming to this particular part about this one, I hope it's clear. You can also write it down here that we also do the reversibility test. And we also expect a 15% deviation, actually. All right. Very well done. An interesting interrelation, a very interesting interrelation. Often in AMC, you will see one disease they will try to compare with another. Now, please mark this word ZORD or ZERD. 30% of the ZERD, as per Davidson's medicine, has association with the asthma. 30% is associated with asthma. Did you know this information before? I think those of you who read Davidson, maybe you must be knowing this thing. Okay, let's go into a little deep down. Have you heard about ZINA guideline? ZINA. G for gum. Yeah. ZINA guideline for asthma. That's the biggest guideline for asthma. Even though for Australia, there's John Murtagh, then asthma handbook available for Australian guidelines, RCH guidelines available for asthma. There's many, but the biggest guideline and even bigger seminars happens regarding asthma is called the ZINA guidelines. Now, I'll like to tell you two level A evidences. Now, how many of you ever done a research publication, guys? How many of you ever done a research publication? Maybe you are an author or a co-author or something. Anyone here? No one? Okay, it's okay. All right. Oh, very well done, actually. I mean, so you must be knowing about the level A evidences, actually. Now, there's few things, lot of things are taken for the research. Like some are randomized control trials, some are like this, some are like that, right? So the best qualities are like, like meta-analysis, you must be knowing it, right? Systematic review, with meta-analysis. Someday I'll teach you these things in the population health, medical ethics, that particular part. So meta-analysis, systematic review with meta-analysis are the best level of the journals actually. Even by comparing so many systematic review with meta-analysis, they usually come to a point with larger group of population or studies when they do, and then it becomes a level A evidence. It's not one meta-analysis, multiple meta-analysis together when it comes to an evidence-based thing. So level A evidence here, we go. Uh, any idea, any cases? Okay. Now, in terms of treating asthma, in terms of treating the asthma, you know, we use the nebulizer and we always think acute asthma always need to treat it at the hospital. But for asthma, nebulizer and the spacer, the picture you can see here, the person is taking using a spacer. So this inhaler device using a spacer, you can almost get the similar effect as like a nebulizer if you use it properly. Am I clear, guys? So this is under Zina guideline level evidence. This actually, when it was discovered, it has a very big impact on many asthma patients in the world by the simple device, this spacer actually. Okay, so it's nebulizer and a spacer. So the home management of acute severe asthma tremendously changed when this particular device came up actually, and it's a level evidence and it is almost similarly effective as a nebulizer. There's another second level evidence I wanted to tell. You all know, I mean, we know that IV works better usually. Um, there's that thing, but injection hydrocortisone, which is a part of acute severe asthma, we'll see that very soon. Also using the oral prednisolone is almost having similar efficacy unless people having diarrhea, which is a different thing. But injection hydrocortisone and oral prednisolone works almost similar efficacy. So these are the two level evidences you need to remember. Okay, this will help you even knowing a asthma patient and in AMC. Okay, great. Now let's get enter into this. All right, great. Speaking about this kind of charts, like using occasional use of Saba. Now, this chart, I mean, we will get it again later. At the end, as a similar chart is given. Now, a lot of people don't have asthma all the time in the year, only maybe in the winter time, a little exacerbation because of dust, because of cold. So for them, it's not a continuous treatment, it's an occasional Saba, salbutamol. Okay, for now, just remember that because this chart I will show you again at the end, actually. Great. I highlighted something that prednisolone is a major lifesaver. So is the injection hydrocortisone. There's a thing called reliever. There's a thing called preventer as well. So preventer and a reliever. Okay, so these are the two things actually. One more thing I want you to also highlight about this sodium chromoglycate, chromes you can also say. So this one is available in multiple form because if we talk about the preventive, I repeat, children's asthma, we also think when think about preventing, usually the steroid thing always comes in our mind. But do remember, sodium chromoglycase is a preventer, and many time it will be given in your exam. I repeat, so sodium chromoglycate will be tested in the main exam. Sodium chromoglycate thing will be tested in the main exam. So some cases they also ask as an inhalational route, which one is better? It is ICS, which is steroid, or is it a sodium chromoglycate? So even for children under 5 years, now this brings us to the point, even though it will be a discussion topic for next question solving day. I repeat my question, preventive. Preventive, child's age is 3 years. Okay. Preventive for asthma, child is known case of asthma already. And now uh, the SABA, the salbutamol is not working well. You need to add a preventive therapy as well. What do you prefer? Sodium chromoglycate or would you prefer steroid, corticosteroid? we'll use the sodium chloride. Now, why not steroid? It's very popular. It's easy to use. It's like very good and even more effective. Then why I'm using sodium chromoglycate? In the case I said 3 years, because 3 years kid will have growth related problem, right? It's just below 5. So here is the thing, below 5, I repeat, below 5 will not much recommend uh, steroid. The important question, and AMC will always full of twist and turn. If sodium chromoglycate is not an option, then we can choose the steroid. Okay, remember it. There was another twisting question with the same 3-year child. So best form of preventive in a 3-year in inhalational route. A lot of people think, okay, now I think they are talking about, you know, probably steroid, because steroid is through nebulizer inhalation form available. This brings us to the point. Is sodium chromoglycate inhalational form available or not? Sodium chromoglycate inhalational form available or not? Yes. As per the next page, sodium chromoglycate as an inhalational form, it is available. Sodium chromoglycate also available as a dry powder. Yeah. A practical tip to you guys, that dry powder thing, is it recommended in acute severe asthma cases? Dry powder thing, is it recommended in acute cases? Think. If no, why are you saying no? Please clarify in the comment section, guys. If no, you see, it's a dry powder, you have to crush it and then with a full force. Now, when the person is having acute condition of asthma COPD, can they do this kind of, inhale, like, so dry powder, how it looks like a small capsule, you crash it and then you have to take like that. They don't have that kind of power to inhale that because they're having breathing problem. Okay, so the twist this. So always check properly while recommending the treatment. So when the suffering is ongoing, you need to relieve that suffering. So those dry powder things, and some people even in spite treating, it's quite continuous. They are even at the resting period. They keep having these things. So some doctors said, okay, you use the nebulizer today at hospital, and then you go and then you start using the dry powder. Is that again a right treatment? So many professor even does a big mistake on that one. You first need to check your patient. I mean, whether patient is following up well. When the patient is actually following up well, I mean, they can actually have that capacity to inhale and do that, then only give the dry powder inhaler thing. Otherwise, it will go into waste. Yeah. Yes, nebulizer, if necessary, later spacer. That's also better. It's that better. But the dry powder one takes a little time when the patient is actually or fully stable. And you are all are right on that answer, I think. Okay, great. This brings us to the point, exercise-induced asthma. Now, I would like to categorize this thing as a little separate. Okay, because it's also under the asthma, but you should read it as a separate disease, like a exercise-induced asthma. Now, exercise-induced asthma, as per the RSCGP guideline. You all heard about RSCGP, guys? I mean, some of you are new, RACGP. Even you will do your assessment someday through the RSCGP or AFRA, right? Okay, so remember the RSCGP. So RSCGP guideline, you can find, like, you can type asthma and you can type in the Google RSCGP. They will directly take you to the RSCGP um, website. All right, coming to the point. Now, as per the RSCGP and as per the SAGE guideline, I double check this one. For exercise-induced asthma, there was a question in one of the recall. Which one is the best preferred? Best preferred treatment for exercise-induced asthma. Because so many names are given. If you see this table, there's so many names are given, right? So what do you think? Final answer is a salbutamol. Now, if salbutamol is started to fail, we go for a combination. Okay, if salbutamol fail, we started to going in a combination like sodium bromoglycate or other things actually. But so far, I have seen the question coming. The best preferred treatment in exercise-induced asthma is the salbutamol. So basically, the kids who are having asthma, is it recommended for them to play football, do normal activities? Absolutely. Absolutely normal activities. Just have to be a little bit careful that before any hard games or hard exercise like football and things, make sure they take the puffs, they take the salbutamol before they play these things. And if it is not controlled, then that particular time not recommended. See, asthma also improves over the time. Some cases early they have atopy more, allergies more, so they have asthma. Have you heard these things? Many people they usually say in the history they had some sort of asthma in the early phase, then it was never there. Or maybe some of you might have this kind of thing in your life. It's because of the atopy, because of this issues, immunity is down, maybe you're living in a different areas. So that can be there actually. So asthma is somewhere it's quite a treatable at some point actually, especially if it is early age group. So the doctors in the overseas they ask them to lead a very normal life actually, okay, and a healthy life actually from the beginning, so that this atopy problem goes away, and over the time because it's a fresh lung allergy, fresh bronchus, and all this thing. Over the time, it's become fine actually. So often they overcome the asthma problem. Yes. All right. Cool. So exercise induced asthma, the kids are recommended to use the puff at least 15 minutes before they play football or any hard sports. Clear? Yes. All right. All right. Always double check the technique. Now, if you check some YouTube videos, a patient came and you ask the patient, okay, show me how to use the inhaler device or something like that. Now, some people will also you know uh, kind of like open it like a perfume, and they actually started to spray kind of like that. You will get to see some videos like that. They'll ask, okay, they open it and they spray like that. So you will also see things, and so there's so many mistakes. So the first technique is the checking inhaler technique. Compare and contrast. This thing I will tell you time to time in my classes. Let's compare the same thing with one of the cardiovascular condition, which is the hypertension. What is the most important thing to check when a hypertensive patient came in? Tell me this thing. Anyone? If anyone from previous batch, don't tell it. For a hypertensive patient, what is the first thing to check first? So please use your ideas. Write it down. Whatever comes in your mind, please write down. Yes, please. 10 more seconds. For a blood pressure, I mean, in order to check the blood pressure and this, that, I mean, patient is hypertensive or not. I mean, of course, we'll check the blood pressure, but even before taking the reading and this, that, is there anything? Okay, good. Okay. Someone said is a funny one. I mean, did the person is having asthma or not? Good one. Drug one is a good one. Oh yes, someone said is correct. Cuff size. Is it important, guys? You're almost there checking blood pressure, but the cuff size, is it important? See, there's a universal cuff. Some people they came, their hands are like this big. Some people has a big arm. Some people are because of the obesity. Some people have big muscles. Some people have also very small muscle. So the exactly right cup size. In our country, only one universal size. But if you go to other countries, you see for kids different size and different people, there's a different size of the calf available. So right calf size. Please remember, it's a AMC handbook question. Guys, speaking about the AMC books, make sure you have the John Murtagh AMC handbook and also the some of the books like Kaplan Psychiatry. Those of you who are taking admission, I think we have also give you link of the books actually also, so you can download a lot of books actually John Murtagh ninth edition is new currently. So this one is only recommended to buy the hard copy as soon, because in the classes we know we follow them actually. Okay, so write cuff size. Do you like the technique, guys? Like compare and the contrast. So inhaler technique for the asthma, for hypertensive blood pressure checking, cuff size is important actually. So if you remember things as a compare and the contrast, it's absolutely amazing. Great. A lot of things are there regarding asthma. One of the level evidence we mentioned already, nebulizer and the spacer. Nebulizer and the spacer. Similar efficacy. Almost similar efficacy you get using the injection hydrocortisone, also using the oral prednisolone, almost similar efficacy. This brings us to the point, this chart is probably not there in some of you. Maybe this one you can take a screenshot. This one is a Davidson page actually, by the way. You can see from the box, maybe it looks familiar to you. So immediate assessment. So whenever someone is having asthma, is it a mild, moderate, severe? The severe asthma is very important to rule out, right? Now, when you talk to the person, is it possible to know the person is having severe asthma? Yes. Because if the person cannot complete a full sentence, it's an indication the person is having acute severe asthma. Then few other things like you check pulse, heart rate, it will be high, and you quickly do the peak flow, and these things would be 33 to 50%. Yes. Okay. So that's the thing. So this is one thing. And then coming is a life-threatening asthma when peak flow even falls more, even saturation falls. Oxygen saturation less than 92%. During COVID days, I think we remember less than 92. It was an indication for, so life is under threat. So when it is saturation less than 92%, and the patient will start getting bluish and the chest would be silent, it's very dangerous. So life threatening asthma actually. Now, all these particular acute severe asthma, life-threatening asthma, one thing is common in them, that is hypoxia. Hypoxia. Now, can anyone tell me, if I use the word hypoxia, is it indicating type 1 respiratory failure? I repeat my words again. If the patient is having only hypoxia, can we say the patient is having type 1 respiratory failure? The answer is a yes. Type 1 respiratory failure. Okay, that's the thing. The next thing is coming, you know, uh, another thing, which is a near fatal asthma. Now, how it is differentiated with the severe asthma and threatening asthma? It also has hypoxia, but it has also hypercapnia. Did you remember this thing from your MBBS, that only hypoxia, type 1 respiratory failure, hypoxia and hypercapnia, type 2 respiratory failure? So you can see near fatal asthma when partial pressure of carbon dioxide also raised. The same asthma can be type 1 respiratory failure. It can be type 2 respiratory failure when they required mechanical ventilation, and type 2 respiratory failure definitely required, ICU or mechanical ventilation. Clear this thing? I hope it is. Okay. You check some of these parts. This brings us to the point, a very, very important next section, which is a guideline for using spacer in asthma. Put it as a star, very important. Also write this thing down. I'm going to explain this thing now, which is called rule of six. Giving you a few seconds to highlight this particular idea. We are ongoing in the same chapter, asthma. Okay, great. So in this case, if you can see, normally, salbutamol is the universal, something you need to use it. So if someone is under 6 years, and let's say like up to 25 kg, we started using 6 puff of salbutamol in like a 30-minute period or 15-minute period like that. Okay, so this is the some of the starting thing, actually, starting thing. And of course, we need to repeat the frequency every 20 minutes. Every 20 minutes in fast hour. That's how the treatment goes on actually. So if someone is less than 6 year and weight is less than that, we keep repeating the six puff thing. Keep repeating the six puff. Now, if the person is more than 6 years, I repeat, more than 6 years, and more than 35 kg, I repeat, more than 35 kg, and more than 6 years, then it brings us to the point it's a 12 puff. So you can write it here as well. If 6 year or more than 6 year, it's a 12 puff actually. Okay. So as a repetition of the treatment, you can increase it if someone's weight or age is a little bit bigger. So in little bigger child, we can increase the dose. It looks silly, but this thing has been tested multiple times, you know, in exam. Okay. Don't worry. I mean, in the recall class, I will clarify it a little bit more. For now, just write rule of six. So 6 years is the cutoff value. Less than 6 year, keep repeating six puff. If more than 6 years or 6 years, we go with the 12 puff thing. Asthma in children is very important because asthma often diagnosed in early age group. Yes. No, I think it's about repeating the dose. You see, every 20 minutes, we are mentioning that the repetition of the doses, frequency about repetition of the doses. Okay. Here is a point. Using the inhaler device, already we mentioned that if you use the spacer, it's better. Uh, it's also becomes more easy because this spacer is more like a mask, or there is an option of using a face mask in a spacer. Isn't it that becomes more easy for the small kids? What do you think? Um, Inhaler, spacer, yet need some instructions. But okay, blow all of your air and then inhale. Well, now very small kids cannot do that. So for them, what is the suggestion? For them, the suggestion: inhaler, spacer, and a face mask at the end. Now it becomes like the whole nebulizing machine. Is it clear, everyone? Inhaler, spacer, and lastly comes the face mask. This becomes very easy. So under 2 year with a face mask can use the inhaler. Previously, even those are very small, like 2 year, 3 year, as a management of asthma, they never used to think about uh, treating at home. But now with these devices, it can be treated at home very easily. So inhaler, small spacer, and a face mask. Enough to treat a acute asthma, even at home setting, even under 2 years. Please confirm as yes if it is clear. Inhaler, spacer, face mask. Together under 2 year, yes. All right. Only inhaler, very difficult. See, at least has to be 5 years. Even required a lot of, you know, instructions and this, that. MDI, my dear, it's a meter dose inhaler. Okay. I was talking about a one chart that I will show it to you guys again. This was the chart. It's given in better form now. So, first of all, mild, moderate, severe, and there was another one, occasional or intermediate asthma. Intermediate asthma means only maybe winter or maybe after 2 years again it came back. So it's like a intermediate asthma or like occasional asthma. So occasional asthma you treat it occasionally with a salbutamol. Okay, so that's a one separate category. It is not included into the chart, but I want you guys to write it down actually. Okay, so occasional cases you write it occasionally. Okay, coming to the point, mild, moderate, severe cases. Mild case you see like a almost 2 months. So yearly like a 4 or 5 times. So weekly like this. So it's a salbutamol again. Now If it is happening like a 1.5 monthly or like a monthly basis, now do you think you need to increase the treatment? Please comment in the comment section, guys. If you think if the person is having every month one particular attack, is salbutamol is enough? Not really. Now I need to add more treatment as a combination. Asthma often is a combination of treatment. When you give things as a combination, it works really better. So as a combination, sodium chromoglycate and ICS depends on the age. I already mentioned less than 5 year. You think more about the sodium chromoglycate, more than 5 year. Inhalational corticosteroid more recommended. Why not corticosteroid early age group? Because it can hamper the growth. Now, if it is becoming weekly problem and night symptom at the same time, I particularly highlight the word night symptom. Here is a small story that, by the way, I'm also a respiratory physician. One time during the training, one of my elder brother, I was the youngest in that program. One of the elder brother, he was telling that, okay, so he lost a relative or some kind of patient of his, uh, because he probably didn't give good treatment, because when we were hearing a lecture from the professor, I says, what happened? Say, the call came at the night time, and now I understand why night calls are so important. um, Even that patient was given the instructions and the treatment in past, and he was a bit busy, and night time it was called, okay, the drugs I gave you, please take them. Actually, he usually have the treatments like, uh, what should I say, the salbutamol and probably the ICS. But when someone is having acute severe asthma at night time, listen to this part carefully. You might save a patient in future. When someone is having nighttime symptom or maybe midnight or something, is this inhaler devices, and of course they don't have a space at villages. Uh, these inhalers are enough to treat. Let's see your ideas. Of course not. Yeah, because first of all, it's an inhaler. Even if this spacer sometimes can be difficult because you need to do this kind of thing. So you probably need face mask in that case, which probably as a villager they might not have it. Okay. So what is the missing puzzle in the treatment which could have taught actually the next day the patient died actually. The next day actually the patient died. Now what one thing he could have given which was very much available in every pharmacy. The answer is a tablet prednisolone. Again, injection hydrocortisone and tablet prednisolone is of similar efficacy and absolutely safer in acute severe asthma cases. So that is something useful. I wish I mentioned him now. Please go and get the prednisolone actually. So that was the missing puzzle, missing instruction actually. So you can see when it is severe and night symptoms. So SABA, ICS, no matter what, you still need to add oral prednisolone. Okay. Are we clear most of the things about the asthma? And so as the prophylaxis, sodium chromoglycate, up to 5 years, fluticasone or ICS when more than 5 years, which is the prophylactic treatment in asthma. These are the questions they see. I mean, I can take like 4 or 5 days things regarding the asthma. But thing is, usually we try to highlight those things come in the exam more actually, right? So these are some of the asthma related important thing for your exam actually. Okay. Is it clear so far, guys? Asthma related things, please let me know in the comment section. So far, is it clear? Asthma related thing. Okay. So a bit in the ninth edition. Yeah. It's already mentioned. Um, Page number 872, exercise into asthma, SABA, then danger sign of asthma, life-threatening asthma we mentioned, the rule of six we mentioned, yes, then this meter dose inhaler thing we have mentioned, yes, Yeah, we'll clarify it to next day. Don't worry. You need to see few MCQs. I think it will be more clear next day. Okay, no problem. I think this one is also clear. And last but not the least, this particular chart. This particular chart, like a 2 monthly. Then if it's let's say 1 monthly, it's easy to say when mention like this 2 monthly, 1 monthly, and like a weekly and nocturnal symptom. Okay. So occasional cases, occasional asthma. Okay. I hope this is clear to all the doctors. Okay. If anyone joined late, we do have a routine already mentioned, as you all can see. We started with the medicine, then respiratory ongoing, then GIT, cardio, renal, rheumato, and all these things. Followed by there'll be surgeries, there'll be INT orthos, gynae obs, then there'll be psychiatry, ethics, and a lot of miscellaneous things. Mock would be every week, and this, that. All right. If anyone joined late, I hope so. Okay, after the asthma, very, very important thing is COPD. Number one thing to rule out. When you know about asthma, this is part of the COPD. So COPD is the immediate next chapter of the asthma, as you all see. But before going to that chapter, it's very important to know the asthma and the COPD. Okay. Someone asked, so to exercise-induced asthma already mentioned, like with SABA, you can use the sodium chromoglycate, or you can use the LABA, is another one. So SABA and the LABA together, long-acting ones actually. Okay. Is it you need to go as a combination? Yes, my dear. Coming to this point about the asthma and the COPD, basic differences about the asthma and the COPD. Now, you must be knowing that COPD is a late diagnosis, means after 40 often, then there's someone is using 20 packets of 20 sticks of cigarettes every day. Both of them have quite a common symptom cough, dyspnea, wheeze, chest tightness. One thing I want to highlight the breathlessness problem is more prominent in asthma. I repeat, breathlessness problem is more prominent in asthma, whereas cough is a more prominent in COPD. There will be hypertrophy of some of the gland, actually, exactly gland name, I think Brunner gland or what gland, I forgot the name. But there is a hypertrophy of the glands, and so there is so much cough is produced overnight. And the COPD patient, when get up, the first job is to clear the lungs by coughing. You often hear COPD patient is coughing for many, like, hours, probably like hours, they're just coughing at the morning to clear all the lungs, right? So that's COPD actually, and they are prominently smoker or maybe a passive smoker. Maybe the husband is or the partner is smoking, the other person is affected, or even some people ask, yeah, I never smoked. I'm just a housewife. Previously we used to find this kind of thing. As per the history, like some people used to use the wood things, actually, wood, coil, this thing. The fume that comes from that part is also dangerous. Okay. So here is the thing I give you guys, because we all go for cooking, right? Actually. So here is a two tip for you guys. When you are doing cooking, if it is possible, also use mask, no matter what kind of cooking you're doing. You should also use sometimes sunscreen while cooking, actually. There's the violet rays are also produced, actually. So some people think, actually, okay, it's just only the sun, but why I'm getting dark over the time? So, here's two tips, actually. Like, either use a proper mask, might help you not getting those uh, smoke, and also the rays, actually. Yeah. Or if you're not using it, probably use some sunscreen. Yes. Okay. Clear, everyone? Some small life-changing tips. Okay. We already discussed about the asthma and the COPD. FEV1 by FVC test, there will be less than 75%. And we talked about reversibility test. Please confirm in the comment section if that is clear, the reversibility test. Yes. So before entering into the COPD thing, um, yeah, I thought of, yes. So my dear doctors, it's in the page number 879 in ninth edition and 881 in 8th edition, 881 in 8th and 879 in case of ninth edition. Good. Okay. Of course, we can check the SMN notes. SMN note has asthma, COPD, all this section. Sometimes we open it, sometimes we don't, depends on. Um, so, are we clear about the differentiating point, guys? Just two slide. Okay. This one, okay, I'm zooming in so that you can take a screenshot probably. I think this one is there in the note section, so you don't have to worry much. Yeah. So age is a parameter. My tip here is cough over dyspnea. All symptoms are similar, but cough over dyspnea and FEV1, FVC less than 75% both, but reversibility test positive for asthma. One more thing in the treatment. Ipratropium, which is like anticholinergics, works better in COPD. I repeat my point. Ipratropium or anticholinergic works better in COPD, whereas salbutamol or prednisolone, these things works better in asthma. Okay, everyone? I hope that's clear. Okay, one more slide. Now, when we talk about COPD, chronic obstructive pulmonary disease, so much cough and this, that been produced. Smoking is one of the major chronic bronchitis and emphysema, blue bloater and pink puffer, two things. Interesting. Uh, very, very popular in the exam, and it comes as a disease. And in the treatment, number one, what is the number one treatment for COPD? Can anyone tell me what is the number one treatment for COPD? That's very interesting because it came in exam. So in the option, ipratropium bromide, smoking cessation, steroid. So what is your number one treatment for COPD? Answer, stop smoking. Now, interestingly, uh, cessation of smoking. Someone also mentioned here, I think, cessation. Is this a good idea? Cessation of smoking means you gradually cut it down, or cessation. Cessation is not a recommendation. You need to quit smoking. Quitting smoking, actually. Okay, stop smoking or quit smoking. Cessation is not this. So cessation is a wrong answer. Okay, so I'm telling again, smoking is number one. You need to understand that smoking is number one. Then there is many other things: short acting LABA, LAMA, Ipratropium, long acting oxygen therapy. Let me clarify. In case of asthma, high flow oxygen. In case of COPD, low flow oxygen. Right? In case of COPD, low flow oxygen. I'd like to introduce you to another term, chest physiotherapy. Are you guys familiar with that one? Conditions like bronchiectasis, conditions like any major lung condition includes chest tapping or chest physiotherapy, this particular word. So this COPD and this bronchiectasis, cases, also some cases, lung abscess cases. This chest physiotherapy may work better. Now, uh, what we can do now, we can enter into the COPD. I wrote down few points. See, versus asthma. Whenever you start COPD, remember someone is a smoker, someone is over 40. Yeah. So that's, and maybe a barrel shaped chase. I repeat, a barrel shaped chase is a high likely a COPD case actually. Then few things are the respiratory finding, like uh, some of the respiratory findings would be there actually. Partially breathing, yeah, barrel shaped chase, yes. So this is common, preventable, treatable disease. By definition, abnormal and permanent dilatation. So you can also write it. This is an irreversible disease condition, lung condition. Yes. So smoking cessation, chronic bronchitis, abnormal and permanent dilatation, and alveoli are at some point destroyed. And if we highlight, cis smoking is the number one. So active, passive, even air pollution. See, if you're living in countries like Bangladesh, India, Pakistan, these areas, do you think even without not doing smoking, can we also have asthma type problem? Like just think. There was a research I was seeing that living in Dhaka city, in main metropolitan area, even if you are not a smoker, you are taking 6 cigarettes per day, technically. Okay. 6 cigarettes. I mean, even not being a smoker. Imagine the level of air pollution. Our nearest, I think Delhi and the Karachi are two of the more polluted cities. I believe. I think Delhi also has a situation where I think the skies become whole dark because of air. I think it's already hitting or coming up. I think I was seeing the weather forecast. So everyone for next 7 days, even if you are in Bangladesh, India, any nearby, so these areas are having some air pollution actually. Yeah, coming up. I don't know from where. So see, air pollution indoor and the outdoor. There is a device I would like to say. Here is another tip, life-changing tip for you guys. Earlier I gave one. So if you can keep, if you're staying yet, there's a big reason you can shift to Australia. This is interesting. And your parents are still here, and many friends are here. You can recommend an air purification, or it's called the HEPA filter. Okay, very very useful thing. So that actually filtered the air actually into normal level. Very interesting actually. Otherwise, indoor, outdoor, wherever we live, we are just keep inhaling like cigarettes. Even we are not smoker actually. Okay, understood? Everyone. Very important. It's called HEPA filter. Maybe air purifier. Much needed. Countries like ours. Now, familial emphysema it can be alpha 1 antitrypsin deficiency. Anyways, breath sound can be bronchial and hyperresponsiveness. These are symptoms. So, cough over dyspnea. And in the investigation, we already mentioned if you do an APC and then in the X ray, why we do it to rule out the other conditions like pneumonia, pneumothorax. Even in asthma cases and in COPD cases, in acute condition, it's important to do ABGs to rule out any acidosis or alkalosis. Yeah. This brings us to the point to a chart stepwise approach to COPD, as you can see. We start the same thing with SABA. With SABA, we can add LAMA and also steroid. Understand one thing, as in asthma, steroid is mainstay. In COPD, steroid is not the mainstay, but yet we use it for the response. So anticholinergic is the mainstay here. Condition like asthma and COPD, we always use some sort of combination of treatment. And also, I was talking about the chest physiotherapy. It's always very helpful for recovery. A lot of things are given. You don't have to worry much. Uh, Important information. Do we need to read doses, doctor, for MC? No, we don't need it. Okay. That's a good news. Okay. Here, sometimes they can ask you things, indication of antibiotic in different conditions. Okay. So, because these are important diseases, so indication of antibiotic, you can check it for both asthma and the COPD. They can put you in some situations like this. All the treatments and this that given the doses, we don't need it. And here, your 885 for ninth edition, it's given. So, management plan for acute exacerbation of COPD. They start with the SABA and then they use the ipratropium. So, ipratropium is a must. Please write it down here to your book. Steroid considered, but not the mainstay, but still they consider it actually. Antibiotic, if indicated. So, read the indication of antibiotic from this particular section, from page number 883. It's a nice to know for this condition. Okay. Great. Are we clear about the asthma and the COPD? We can go for a short break, and when we come back, I think we can get into uh, some of the conditions like restrictive lung disease, some sort of conditions. Actually, there is a chapter called dyspnea. We will get into that particular chapter, which is page number 463. Okay. Can you go for a break now, guys, if it is okay? Yeah. Don't worry, I'll give you some time after the class to answer some of your doubts about the courses and this, that. Anyone joined late, I think we already posted the class routine. We started with 14th, fresh start. And this to a trial class. If you have a friend, yes, break time, my dear. Now, 10-minute break now. You guys come back after 10. Then pediatrics, surgeries, medicine is quite long and it's a very good classic routine. So theory, recall, then I will also give you question banks and I will also give you mocks, definitely. And so it will be together helpful at least. We have been running classes since last 9, 10 years and 1,900 and passed if we add the last November doctors actually. It's a very huge amount of numbers. I know every doctor in every hospital in Australia. Okay. I mean, those been through us in last 10 years, actually. I strongly believe you all will be there, actually. With your proper study, hard work, and with our guidance and this, that, of course, it's doable. You have to believe it. It's doable, actually. You need to give your everything. I'm telling those of you came here half-heartedly, uh, first of all, I mean, if you are in doubt, they said, let's see how it happens. You don't need to join my courses actually in that way. If you are really serious about Australia and the AMC, feel free to join our courses. And some of those doctors, like uh, actually very busy practitioner, like someone working in ICU as an anesthesiologist, we really respect them because they don't have a choice. They're consultants. In that case, instead of live, there is a recorded course, which is a replica of our live. This live batch contents also we upload there. You can also follow that one in that case, actually, but you have to tell about your profile to us in that case, so that you really have that kind of difficulties. In that case, we'll switch you to those kind of courses, actually. All right. So let's go for a 10-minute break. When we come back, we'll continue from here, actually. If you have any concerns about the course, you can inbox me now, but probably after the session, I will answer you back. But feel free to inbox me if you need anything by Facebook Messenger. Thank you. Okay, everyone, are you guys ready to start the session? Do let me know in the comment section if you are ready. Comment as the ready so that we can start. All right. All right. So, guys, I'll be uh, guide you a little bit on to the screen. Only my video is available at this point. Just guiding you a little bit about our SMA note, which some of the doctors probably have asked us. All right. So here we go. This is how it looks like, my dear doctors, like the SMA notes by Dr. Shahriar. I think I have sent you already, most of you, unless today some people took admission can be different. No, when you start, this is how it looks like. So you have to go to the medicine section first of all, especially medicine, and then um, especially the respiratory one actually. So let's see next day the GIT. So you can read it in advance actually if you want. Okay. So as we can go, yeah, there'll be renal in future and the respiratory. Now, if you can see, I'll be taking just 1 minute to demonstrate one to few here. If we just click any one of them, yeah. So we'll be open up. Yeah. So some interesting things you will find, which will be necessary. Yeah. So necessary things, yeah, see the slides today we gone through. Then um, the COPD is another one. There'll be lung cancers. Yeah, as you can see. Yeah, we'll come to the lung cancer part. Don't worry. Good question is SMA node. Now I'll take that question. John Murtagh, SMA node. Uh, the recalls we solved on the Thursday, and some of the instructions been given on the classes actually. So which also includes in future like doing a little bit question bank, and also there is a forum named Shahriar's AMC Guideline Forum. How to utilize that forum, and very important, you're having some discussion with a study partner. If you go too much solo, all this thing you cannot remember big gigantic things actually. So the potent study partner you guys have. So it's more easy to find a study partner in the beginning of the courses. I'm telling you enough and finish all these things together, maybe two or three people together, the best results and the outcome. I think that helps with your answer. So for the theory, it's SMA note and the John Murtagh. That's the best combination. And then comes the recall, then some of the things from the question bank, which we will provide you, don't worry. And so as yeah, to the point study is more important. Okay, so I repeat, to the point study. I mean, something which is tested in exam in past is more important for you. Okay, this is how if you study, it will be extremely beneficial for me. Great. Okay, coming to the point. Yes, our next things which is gonna come up is some of the dyspnea chapter. In this dyspnea chapter, nothing too much we have here except for few of the restrictive thing. Let me tell you the page number. So dyspnea in elderlies. See, respiratory and cardiac can be related often. Why? It because the breathlessness can be cardiac as well. So whenever a patient, especially after 50, comes to the hospital, you definitely need to rule out cardiac, but even early ages, it's also possible, right? If they have a congenital heart problem. So you need to know the differentials of any dyspnea. I hope that's clarified the things. Now, coming to the restrictive, now, did you remember, guys? Let's recapitulate some of the restrictive lung diseases. Anyone? Yes, which includes fibrosis, which includes interstitial lung disease, which includes sarcoidosis, right? And the pneumoconiosis. Few of the criteria like FEV1 Hep C by spirometry is 75% or raised. Did you remember this information? Please at least write it as a yes. FEV1 by Hep C by spirometry in restrictive lung diseases, normal or increased. Okay. So it brings us to the point residual volume decrease, total lung capacity also decreased in those cases. Right. An example I just have mentioned now, and a special feature clinically, there is a possibility of crackle, but crackle can be present in many other conditions. But inspiratory crackle can be a sometimes a DD for you actually in these cases. Now, if we talk about lung fibrosis, how do you understand? Now, I see the clinical findings, also like the trachea centrally placed on north. Some of the cases like pneumothorax, fibrosis, these cases, trachea is usually not centrally located. Towards the disease is a fibrosis, which you can see by X-ray, and some of the other lung findings and high resolution CT scan will also give you more clear view. So how to confirm a lung fibrosis? If I ask you this question, even though lung fibrosis is nice to know for exam, quick question: how to confirm lung? We start with X-ray. Normally, we diagnose, we get idea clinically, we do an X-ray, then how to confirm? Do I need a biopsy for fibrosis? Not really. So high resolution CT scan here is probably the like scans are effective for the diagnosis is actually. But if you think something else, it can be cancer, it can be something else, then you can consider biopsy. But otherwise, high resolution CT is enough for these cases. Now, if we go back one or two pages, here is something you all can see. Comparison in different lung condition, like say breathing, percussion, then the abnormalities and these type of few things, asthma, bronchiectasis. These cases we're expecting wheeze and vesicular with prolonged expiration things. Even though bronchiectasis cases, we can get bronchial instead of vesicular. Normal sounds is a vesicular. Normal sound is a vesicular actually. Now I highlighted on the important that when you see lobar pneumonia cases, again inspiratory crackle, but this crackle thing also presents at the same time in these restrictive cases too. Okay, like see fine crackle. So I think it's better to say the fine crackle. I think I choose the wrong word earlier actually. So the fine crackle I think is a better word for the fibrosis or some of the interstitial cases. Whereas condition like pneumo and the pneumothorax cases, there will be decrease air entry into the lungs. When you put the stethoscope, you understand very clearly. And when you percuss, in percussion note pneumothorax cases, we all know it, it's a hyperresonant. Whereas hemothorax cases, which is not mentioned in the slide, please write it down, this small thing, 467 page. In this case, hemothorax cases, it would be dull instead of hyperresonant. Dull instead of hyper, because it's blood underneath and it's air underneath, so hyperresonant. All right. Stony dull you can get in cases of pleural effusion. Pleural effusion is nice to know. It's more like a symptom rather than a disease. So pleural effusion, I recommend you to check from the MBBS knowledge which of them are exudative pleural effusion, which of them are transudative pleural. Often pleural effusion comes as a uh, gateway for pneumonias in the exam. Okay, they give you X-ray of the pleural effusion and you get idea from X-ray and the clinical scenario, your diagnosis of a pneumonia, or they ask treatment for pneumonia or related condition. Okay, so consolidation valve, respiratory crackle, this, that. So you check this one, double check, would be much more better. Coming back. Yeah. So interstitial lung disease, nice, just nice to know. I haven't seen much question coming ever. But the question that comes more actually from the sarcoidosis, actually. I repeat, question comes more from sarcoidosis. This brings us to the point, would you like to put sarcoidosis? I always start any disease like this. Would you like to put sarcoidosis as a only respiratory condition or is it a multi-system? Why do you like to put sarcoidosis? Answer, it's a multi-system. As like compare contrast, rheumatoid arthritis is a multi-system condition, right? So this one is a multi-system. SLE is another multi-system. Yes. So this one is multi-system. So among the respiratory, many other conditions. This one is a multi-system. And one to autoimmune diseases like Wegener's granulomatosis, these are also multi-system condition. Now, very, very unique finding is a lung fill shows in this near to the bronchus areas, bronchial areas, bilateral. What is that finding? Yes, bilateral hilar lymphadenopathy. For sarcoidosis, bilateral hilar lymphadenopathy. This is the most important thing. Now, more features. There's a skin finding too, other than the malaise and this, that erythema nodosum. Very important for the exam. They often give a picture of leg, so it can be erythema nodosum. How to diagnose? We do biopsy, mostly skin biopsy or a lung biopsy we do for these cases. So mostly lung biopsy is preferred, but lung biopsy not in option. Skin biopsy, you can do it actually. I have seen both coming into the exam as a lung biopsy and a skin biopsy. So since sarcoidosis, multisystem disease, autoimmune, all these things are related. So you can also use steroid at some certain point actually. Okay. Now about sarcoidosis, what's given in our SMA note. Let me bring it for you a little bit. You will also find it in our SMA note section, same one. So sarcoidosis. Okay. Let me highlight with the X-ray. Can you see both sides, some notes? I ask you guys again. Can you see some sort of abnormality in the both side? So both side, I can see some notes. So this is a classic bilateral hilar lymphadenopathy. Bilateral. So it's a restrictive lung disease. These things decreased, already discussed. Unique feature bilateral hilar, both sided. Skin lesion showing erythema nodosum. Now, speaking about erythema nodosum, this is the picture about the erythema nodosum. Erythema nodosum. When you examine this patient, usually unremarkable, rarely inspiratory crackles you can get. Rarely inspiratory crackle or fine crackles you are expected to get. Now, this is interesting for every respiratory condition. I'm giving you a formula. We start with X. I mean, of course, we do clinical examination, then we start with X-ray. Then, if needed, we go for a CT scan, generally CT scan. And then, if needed for a DD purpose, or if you find any abnormality or suspicious something, we go for a lung biopsy. Mind it, lung biopsy is very painful actually because it pierces the pleuras and this, that. Some cases, I mean, in lung cancer, we'll see, is it a lung biopsy or are you going for a bronchoscopy? We'll discuss about that one. But sarcoidosis is a restrictive lung disease. These are restrictive lung disease finding. This is a unique finding and this is the skin finding. Multi-system involvement, lungs, eyes, heart, liver, skin, all these things can be involved, especially the skin condition to remember. And this is the physical examination. And this is the investigation. As a treatment, we give supportive treatment and we can give steroid. Okay, is it clear about sarcoidosis, everyone? Is it clear about sarcoidosis, everyone? Please comment in the comment section. Yes, okay. Okay, so we usually try going for specific one. Specifically, we try to study things actually. Clear, right? Okay, so if we have finished this restrictive sarcoidosis, then we go for one page next to sarcoidosis, which is a, uh, what is that? This is occupational lung disease. We often known as pneumoconiosis. Now, this is something related to occupation. Someone working in a coal mine or coal mine, they can develop coal miners pneumoconiosis actually. Again, they can have some fine crackles. They can also develop silicosis if someone is working in a mine or sandblasting, these things actually. Someone can develop asbestosis. Now, I want to highlight here, yes, like about this asbestosis thing. About this asbestosis thing, uh, are you familiar or heard about this condition where asbestosis is more common? I'm sure you heard about this. Asbestosis is more common wherever there is some very old houses out there. Asbestosis is more common where there are a lot of old houses out there actually, right? So it used to be more common in past. Now the buildings are changed, but there were few buildings like 100 year history. So from the wall and from this part, people living in the same house develop asbestosis actually. Also mining, shaping, these things can be related to asbestosis. I want to highlight here our page number 473, John Murtagh, ninth edition, with the word asbestosis. Please give it tick and please mention asbestosis can lead to, I repeat, asbestosis can lead to lung cancer. Also another arrow, asbestosis can lead to another arrow, mesothelioma, right? So it's a plural cancer. Yes. So lung cancer or pleural cancer, asbestosis can be interpreted. It can be often presented as a simple pleural effusion, right? So and later it turned out to be a cancer. Okay, we have seen cases like that. Another thing we want to highlight, what is that universal lung finding, X-ray finding of pneumoconiosis? Can anyone tell me in the comment section under 15 seconds? Yes, please. What is the X-ray finding? Mostly cases for pneumoconiosis. Of course, we do CT scans and this, that. Not really coin nodule. Possible. Those are some individuals, but one more thing, guys, one more chance. Have you heard about ground glass appearances? Have you heard about the ground glass appearances? So ground glass appearances here are also respiratory distress syndrome in pediatric. Somebody will teach you actually. Okay, so ground glass appearance or ground glass opacity is one of the key point. Am I right, guys? You can double check if I'm wrong. Yeah, so ground glass appearance you need to remember. Respiratory distress I will discuss in the pediatric. So there's an adult version, there's a pediatric version. We prefer the pediatric version comes in exam more often actually. Now the famous COVID-19. How many of you ever had COVID in your life while treating COVID or not treating COVID? How many of you already have COVID in past actually? I'm sure many of us. Yeah, some people twice. Yeah, of what like what days were there, right? Yeah. Two, three doctors said, Doctor, I feel like, after having COVID, my memory also started to get affected with over the time. Do you believe that? I'm not sure, guys, because we are the one who had COVID most often, actually. Yeah, but some people say it's like there are studies going on, but some reports show, some people are like, we don't know really long-term memory affected or not. Now, coming to the point, it often can remain asymptomatic nowadays. But I believe my after the AMC course started, it will not affect if you anyone having COVID twice. I hope so. There won't be any problem actually. Uh, anyways, so often nowadays it becomes like a mild symptom, as like the influenzas and this that actually. So fever, dry cough, and this that. Who said 4 times? Okay, what you are doing? I mean, is it because of work or COVID was looking for you? Oh, okay. Okay, fun apart. So fever, dry cough, sore throat, rhinorrhea, and very interesting smell. Some people notice it's gone. Okay. So severity can be dangerous. Every single drug, guys, every single drug was tried in COVID, right? Yeah. So every single drug, every antibiotic is like a homeopathic treatment. I believe that COVID treatment was initially is more like a homeopathic treatment, actually. Even some homeopathic doctors were also claiming that their treatment was also working. So everyone is claiming something. Yeah, yeah. Antimalarial was popular. That is not even tried. I mean, we got some result. There was so many, drug combination. Anyways, those people were suffering. They were sent to ICU. Even home, those are having COVID, they were asked because of the patient drugs that if you have saturation dropped less than SaO2 less than 92, then you come to the hospital only, and they were given like this pulse oximeter, right? Yeah. I saw one time in COVID, I think it was in India. I mean, I think in one of the city there was no, I mean, all oxygen were finished actually. Uh, People were coming and dying. Yeah, imagine those days. Anyways, so a lot of things been tried for the COVID. COVID related, we also have a note in our note section. Yes. So fatigue is one of the very common things. 70% report fatigue. Okay. So, anyways, guys, COVID 1 2 question you maximum can see with an X-ray finding in some cases, and just read about uh, the investigations related to COVID. I think we all know about those PCR tests and this that to confirm the further COVID thing. Actually, all right. Now, coming to the important part, which comes so often in the exam, which is the two of the popular diseases coming up now for the exam, which is bronchogenic carcinoma. But you see, the same diseases in actually in AMC written in lot of different places actually. So for bronchogenic carcinoma, we have to go to a different page actually. Yes. So this chapter is known as um, cough. Okay. So I think let's discuss the bronchogenic carcinoma first, then discuss the pneumonia. All right. We do have a SMA note. Like, how about we follow this one in the note first? Okay. Here we go. Must learn things. Okay. Investigations related to bronchogenic carcinoma. Very important. Bronchogenic carcinoma and their paraneoplastic features. Example, uh, there's four types, of course. And small cell carcinoma is the most dangerous one. Did you know this information? Right? I hope so you do. Now, if you have someone having Cushing features, bronchogenic carcinoma and Cushing syndrome like feature, it's an indication this is probably small cell carcinoma. So these are the paraneoplastic features. Paraneoplastic features actually. Also, if lung cancer and there is Horner syndrome, we think this is a Pancoast tumor, right? So these are some of the example of the paraneoplastic feature very often tested in the main exam. Now let us look for two more things before the types. So breathing, coughing, these are very common. These are very common symptom, and of course, the weight loss, fatigue, and I remember one of our um, relative got um, this feature. He was feeling weak over the time. Then we do the X-ray. There was a coin-shaped lesion, and then gradually symptom aggravates. Then there was hemoptysis. Then there was significant weight loss. Then there was breathing problem over the time. It was a horrible experience for the full family. Okay. Now, few of the interesting thing here actually. Okay. About the lung cancer. In a nutshell, small cell carcinoma most dangerous, whereas squamous cell is the most common. All right. Adeno is often hidden, and bronchoscopy is done in central cases. So all these lines are important. I'll come back to those particular lines. Now, let's imagine this is the two lungs. These are the bronchus divided into bronchiole. Focus on the green side, then focus on the red side. The red one is near to bronchus. Now, if it is near to the bronchus, are you expecting symptoms more early or symptoms later? Please answer this one first, actually. I repeat things. The red one cases, are you expecting symptoms early? Yes, the symptoms early. Why? Because it is near to bronchus. The symptoms would be more early. Now, symptomatic, and now we can say so central, it is actually squamous cell carcinoma. So they present it early. It is easy, some cases, to treat if it is a squamous cell carcinoma. Can you say like that? Yes. Now then is another version which happened actually with one of that our relative, and that was adenocarcinoma. I repeat, that was adenocarcinoma. actually carcinoma. And when we do the X-ray, it was not near to the bronchus, it was little away from the bronchus. And that is probably the reason the tumor just grows bigger, 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 and then it comes near to the bronchus. So at that time, it becomes much bigger inside and also goes outside. We couldn't do much because it was almost metastatized that particular time. Actually, we couldn't help much actually. So if peripheral is the presentation, can we say it will remain more asymptomatic? Yes, for certain reason, because it's away from the bronchus and more like a hidden killer. Now, this brings us to the point, your hidden friend is more dangerous or is your enemy is more dangerous? Okay, lesson number 3 today. I think we all had experiences, choosing friends, in life. In medical, we used to see that, someone is not giving us this note, this note, and this, that. So hidden friends sometimes more dangerous. It's your own land and there is a thing can be more dangerous actually. Yes. Yeah. So often close people who hurts you, that felt the most actually. If you're outsider, I mean, you don't care actually, or already that is your enemy. It will not hurt you that much. Am I right? Okay. So here is the thing. So away from the bronchus, peripheral, and it can be asymptomatic, and it's like a hidden one. It's like that hidden friend. Yes. So this brings us to the point. SCC most dangerous, squamous, which is centrally placed. It's at least they will show up. Adeno is often hidden, that hidden friend. Yes. And SCC is a type which is extremely aggressive. At the time you get the result, you will think that it might have metastasis in these 3, 4 days by the result came. This brings us to the point. We'll zoom a little bit. Squamous is a mnemonic, squamous, central, smoking. So all of the lung cancer somewhere related to smoking, except for probably adeno actually. Now, keratin pearl is related to squamous. That's more like pathological, but every squamous things, I mean, not only lung, like cervical squamous, any other squamous will have keratin pearl. This is one common thing in the pathology. And there is adeno, which is common in periphery and also common in non-smoker. And if you remember that relative of mine died because of adeno. We couldn't diagnose early because it was hidden. So it is mentioned not linked to smoking. Then the most dangerous one is small cell carcinoma. And there is few lines are given like say ACTH and ATH. If I be right saying that ACTH is related to cortisol, cortisol is related to Cushing. So if someone is presented with a lot of acne and lung cancer, Cushing syndrome with lung cancer, can we say it's an indication of small cell carcinoma of the lung? I repeat my things. Cushing feature plus lung cancer feature together. So then we'll think more about small cell carcinoma of the lung, and it's very dangerous. Also, ADH, you must be knowing about it. So, high ADH, what is the condition called high ADH? Anyone knows? Low ADH, high ADH, high ADH has a name. It's called SI ADH, SI ADH. I will teach you that part in the endocrinology, very popular in the exam. So these are the paraneoplastic feature, and whereas squamous cell carcinoma has a PTH, parathormone. It is very interesting. So in body, parathormone level will be raised if squamous cell carcinoma is there. Okay, and there will be few which is like a metastatic one, metastasis from the other part and coming to the lung. So that is another actually which can be shown in the X-ray. Now, am I right saying that we start with X-ray, we find coin lesions, then we do the high resolution CT scan or CAT scan, then we find the location, staging, and this that. Then we further do biopsy to rule out the types. Is it a squamous? Is it a small? Our biopsy will tell us that. Right, everyone? Yes. Very rare people survived from lung cancer. Can you name a cricketer? Very famous cricketer survived from a lung cancer. It was stage 2, but he survived. Yes, I think Yuvraj Singh, very famous cricketer. Yeah. All right. I only know about Yuvraj Singh having that one. Okay. So Said Kohli, I mean, I never heard about it actually. Okay, so here are some paraneoplastic features as a complication. Superior vena cava obstruction, Pancoast. By the way, Pancoast tumor has superior vena cava obstruction in any way related feature because when you have Pancoast tumor in the apex of the lung, it compresses the vena cava, then there is superior vena cava, like syndrome. And how do we understand that? One, by CT scan confirmation. But before CT scan, there is a test for Pancoast tumor. Any idea, any cases, the test name? This one is a little advanced question. Pancoast tumor, a clinical test. We ask the patient to turn on a side. Any idea what test is this? No one? I don't heard about like some Pemberton. Yeah. So turning and flashing of the turn and flash of the face. Face become red because of already superior vena cava obstructed. Normally when we don't do it, we do it, it doesn't become flash. But in case of Pancoast tumor, when you do it, it flashes the face. Okay, so that's a sign. And you heard about that lung cancer can leading to hoarseness, even laryngeal cancer related to hoarseness. Somebody in ENT will discuss that in which cases hotness is more prominent. This that. All right. So coming to the point. So SCC, acetate ATH, important. We'll learn about ACTH, ADH, these things in future. And here's the features of Cushing. I'm sure you've all seen this picture in Davidson in past. Moonface, buffalo hum, stria, high blood pressure, this, that. This is another very important part. Asbestos exposure related to occupational lung disease. There was a recall, or recall means actually whatever that has been tested in the exam. We try to collect from our students. Someday you also go for the exam, try to give us feedback, my dear. Okay, so lung cancer more common, mesothelioma less common. Mesothelioma is nothing but pleural cancer actually. Okay, so again, same thing. Asbestos cases, we do X-ray, then we do high resolution CT scan. But if you suspect if say there is pleural effusion or something like that, then we go for biopsy to rule out cancer or type of cancer. Okay, so X-ray, CT scan, biopsy. That is the lineup for the test. Okay, you can find me in social media, guys. Even my YouTube channel. You can check some of them actually. Sometimes I post even in my Facebook. I post my stories regarding the studies. All right. So that's for the lung cancer. Okay, are we clear about the lung cancer, guys? Are we a bit clear about the lung cancer now? Please comment. Okay, let's see what's in the John Murtagh. Few stats they have given. Okay. Uh, Common lethal in both sexes in Australia. We know this. And nothing more. Yeah, here are some physical finding of bronchogenic carcinoma. Okay. Some physical findings. Just have a look on them. Already mentioned that one. So any nodule in the lung by X-ray is very important to rule out by doing a CT scan. It can be a simple mass or bronchogenic carcinoma or whatever it is, or even a cavity. Rule out, very important. Okay. So this brings us to the point mesothelioma, which is shown here, is a cancer of the pleura. It is related to asbestos exposure. But if I again ask you the same question, in asbestos exposure, which particular condition has more chance? Lung cancer or pleural cancer? Your answer would be lung cancer because write this line, mesothelioma is a extremely rare condition. Okay, mesothelioma itself is a extremely rare condition. Clinical features are similar like other lung cancers: chest pain, dyspnea, weight loss, pleural effusion. Okay, I'll show you a picture. This picture I think is taken from Davidson. Mesothelioma. I'll start with a um, prefer with the CT scan because CT scan has been tested last time. Now, this is usually normal, but can you see any difference in this side? Just think logically. Because there is a cancer of the pleura, so the red bar are measuring thickness of the pleura. So the pleura has been extremely thick. So overall, the lung, these cavity spaces are reduced. Correct. So this is malignant, very like dangerous condition, by the way. So thickened pleura, can I say this thickened pleura is a indicator of mesothelioma? Am I right? Thickened pleura is an indicator of mesothelioma. So they will give you eventually some cases a picture of like this. Can you say this one is a very clear case of pleural effusion? Yeah. So they will give you pleural effusion pictures like this along with the clinical scenarios. This picture is from the Davidson medicine. So mesothelioma expecting pleural effusion, mesothelioma expecting pleural thickening, and CT scan finding looks like this. Okay, some cases because these are chronic conditions, so fibrosis-like feature as well um, can be also there actually. Okay. So hope you understood the differences. I hope you understood the differences now. Great. So we do X-ray, we do CT scan based on the imaging. If needed, then we go for a biopsy. Last but not the least, major diseases always check the prognosis. Is prognosis good or bad? Prognosis is very poor. So as the most of the lung cancers, except for squamous cell carcinoma is better, or stage 1 and stage 2, up to probably stage 3A, prognosis is okay. But normally stage 1 and stage 2 are better or operable actually. But normally stage 3B, 4A, 4B, these are inoperable. Yet depends on where the tumor is located. Great. Great. Among one of the, you know, obstructive lung disease, ABC, one of them was bronchiectasis, if you remember, abnormal or permanent dilatation of the bronchi, bronchiole. So they will give you an X-ray or they'll give you a CT scan. There can be finger clubbing, by the way, with a huge amount of sputum, and there is a lot of cough has been produced. Okay. Bronchitis is one of the condition you get to see the patient is always taking some antibiotics because there's always a certain sort of infections because of this chronic coughing and there is cavitary and this that. So episodes of pneumonia again and again. So they definitely need a lot of treatments. So you can see they can also have finger clubbing actually. In one line, if I want to describe you the finding related to bronchiectasis, what it would be. Any idea, any guesses? Okay, it's from a separate book. Its name is Master the Book. Pick up this section because it looks nice. So abnormal and permanent dilatation. Okay. It can be related to hemoptysis, weight loss, crackle in the lung. There can be clubbing too. So again, we like to do a CT scan. And when you do CT scan, it's quite abnormal and permanent dilatations. Okay. Now, there's a special line called tram track appearance. Did you heard about this term? Tram track appearances. So you need regular antibiotic as a treatment, chest physiotherapy, which I mentioned earlier. Okay. And you need to rule out what kind of microorganism is causing it. So you need sputum culture at the same time. If extreme cases, you might need surgical, some focal lesion removal may be required in some rare cases, actually. Okay, I hope that's clear about the bronchiectasis, abnormal and permanent dilatation of the bronchi and the bronchial. We do have also note in the note section. Just like the COPD, they just keep coughing actually. And they also associated with wheeze, and they associated with a lot of infection, which leads them to pneumonia. The first priority to save your patient. So you need to give rotatory antibiotic, chest physiotherapy, and also look out if there is any cavitary lesion and this that in some cases surgery might be required. Okay, everyone, is it clear about this bronchiectasis thing? Please let me know in the comment section. Okay. If it is done, we are talking about the pneumonia and the infection. Let's get into the one of the last important topic, which is the pneumonia for us. Okay, pneumonia and the TB, and we are done. Okay, sorry for keeping wait. Tram track. You can just Google it, my dear. It's because you know the tram lines. I went. Where is tram available yet? I think in Kolkata it is available. I think in some countries in London tram available. Yeah, we do provide notes. Yeah, of course. I think those taken admission. I think till yesterday we provide already provided them actually. Those of you received already notes, please comment in the comment section. Received, mentioned as a received. Okay. Yeah. Okay. Thank you, guys. Okay, taking out the screen and just try to open the SMN node pneumonia section. All right, guys. So we are ready. Okay. First, what is pneumonia? I mean, we all know it. Infection of the lung that is related to pneumonia. Infection of the lung that is related to pneumonia. Actually, if anyone not received note, please you can leave us a message. Probably we will send you tomorrow. Actually, so don't worry. All right. So infection of the lung is known as the pneumonia. We all know that. Okay. There's a lot of types: community-acquired pneumonia, hospital-acquired pneumonia, right? Pneumonia in immunocompromised patients and this that. But main important thing is pneumonia can be caused by many microorganisms, but three of them are very prominent. One of them is a streptopneumonia. There's Haemophilus influenzae, Mycoplasma. The other few, here are the names for the community-acquired pneumonia. Okay. So clinical features would be there. I mean, very, very important line would be high temperature is a keyword. Then fever, high fever with cough, shivering, some cases, because infection, so pain in the chest. So this will be common features. As like for the most of the condition, we do a very quick chest X-ray. Pneumonia situation always do an X-ray to rule out any consolidation. By the way, for the exam, middle lobe consolidations are very popular. They often give you an X-ray finding in the exam, and they say, okay, a 72-year person developed, high fever and this, that, and this is the X-ray. So it's a middle lobe consolidation. In the middle part, there will be some haziness actually. So you have to do tests like CBC, then there would be blood culture, sputum culture, and all these things are important. Okay, X-ray is the initial test in this case, actually. X-ray, then the culture, these are more important. Now, what is important for the exam? Some cases they will give you this common pneumonia, community acquired pneumonia. Some cases they can give you hospital acquired pneumonia. By the way, if you have, if you developed uh, pneumonia or infection on the third post-operative day. Okay. Is it hospital acquired pneumonia? Third post-operative day pneumonia. Is it a hospital acquired pneumonia or not? If no, why not? See, hospital acquired pneumonia, it has to be like in first 48 hours of admission. Maximum can be 70. So it's usually 48 hours. So patient there was a uh, one day before surgery, they admitted. Then there was another 2 days pass. So that's a wrong statement. So that's a newly developed pneumonia. probably pneumonia, immunocompromised because of surgery, or maybe community acquired pneumonia. So we have to be careful choosing the right things in the exam. There's another pneumonia that is given in the exam often. They only mention about dry cough. That's why you should write a line near to this particular area, 402 page. Never ignore dry cough. Why? Because this dry cough can be turned out to be atypical pneumonia. Now, question is atypical pneumonia is also dangerous or not? Yes, atypical pneumonia was caused by mycoplasma, right? So this atypical pneumonia can be dangerous. Now, thing is here, less clinical symptom, but clear, radiological symptom. This is applied for the atypical. So mostly there will be low grade fever and the dry cough. So low grade fever and the dry cough, not classic high grade fever like other pneumonias actually. So minimal respiratory symptom, non-productive cough, fever without chill, X-ray worse than chest sign. So this is your key line. So mycoplasma and Legionella, these are the two culprits actually here. Okay, very, very important treatment of pneumonia. I would also like to address. Have you ever heard about CARB 65 or CORB 65? Have you ever heard about this? I'm sure you do. That it is an assessment of taking the patient to the hospitals. I'm sure you do. Please read it by yourself. Now, antibiotic treatment, they give you some X-ray and clinical scenario, and they will ask you about treatment. Now, if the patient, according to CARB 65, just one or something like that, then you probably don't need much treatment, just mild antibiotics. Only maybe X-ray, it is little visible actually. It does not require any hospitalization, does not require any hospitalization. And simple oral treatments are fine. But if it is moderate cases, now we think there might probably requirement of hospitalization in these cases. Okay, often they are elderly, another thing. So you give benzyl penicillin and this type of things or ceftriaxone in these cases. Severe pneumonia even more dangerous. The patient's saturation will fall, and as per the CORB 65 score, the severity, so it will reach up to like uh, I think three it will reach. So confusion, hypoxia, these things also persist. So again, treatment is ceftriaxone. These are some of the red flags for adults to rule out the pneumonia. Okay, great. So these are the treatment for the pneumonia. When you read the pneumonia for the adult, also read the pneumonia for the kids actually. So it will reduce your burden for future. Okay. So coming to the point, in the notes. Sometimes this kind of thing can be useful for you, but age-wise microorganism. So in the notes, you will find this like medicine, respiratory, pneumonia. So age-wise, like adults, strep pneumonia, in adults, strep, always. Interesting thing, there was in past, there was a question like neonates having which particular microorganism? I remember as a BEL in short. B for beta streptococcus, E for E. coli, L for listeria. So in short, BEL. So BEL for the neonates to remember. Here is a management. By the box you can understand it's taken from a guideline. It's actually RCH guideline management. So if anything related to kids, like so pneumonia management in 1 month old, you can again see amoxicillin, you can again see ceftriaxone and this that particular things. Okay, so understood management well. There's few things related to pneumonia, like this particular microorganism common in COPD, Klebsiella common in alcoholics. Okay, then mycoplasma can be atypical. So atypical is more common in young. So young develop pneumonia, high chances atypical, right? And an adult person develop pneumonia, high chances it's a typical pneumonia. So here is that COP 65. You can see if there is 2 points, short hospital stay. If it's 3 points or more, hospital or ICU. Burn patient can develop because of pseudomonas can have an issue. So it's like here's few things related to particular microorganism and related, like bird exposure, chlamydia, very interesting. Alcoholics, Klebsiella, AIDS patient, pneumocystic kidney. Okay, these things look silly, but this thing can be tested in the exam. Okay, so here's few things about the pneumonia. Are you guys clear so far about the pneumonia? So pneumonia clinical feature, pneumonia investigation, pneumonia management, CARB 65. Okay, these are important. Also, severity of pneumonia, mild, moderate, severe. Also, if you want to take a note, please also check RCH guideline and type RCH guideline pneumonia and check the kids management related to pneumonia actually. Okay, RCH guideline to check the some of the things related to kids, children's cases of pneumonia. All right, everyone. One thing that is not given in John Murtagh, but it comes sometimes in the exam, oxygen delivery system. We already learned a little bit like asthma cases, high flow, COPD cases, low flow, but that is not how always they will ask you. They will also give you some cases saturation based on saturation with treatment or procedure we are using. So you see 91 to 94 nasal cannulas. If below 92, actually like 95 to, sorry, 85 or 86 to 92 somewhere, Venturi must. This has been tested. So non-breather or Venturi if below 92, but above 85. 85 or less, this is something comes in exam most often. So this brings us to the point 85 or below, let's say 82%, what to do? Non-invasive or even 85% non-invasive ventilation, that is intubation or the CPAP. Intubation or the CPAP. Okay, please remember. So again, summary. This case, nothing. Mild hypoxia cases, nasal cannula. Moderate cases, Venturi. Severe cases, non-invasive ventilation, particularly CPAP or intubation. Very high yield for the exam, actually. Very, very high yield for the exam. Okay. One more last topic. Everyone familiar with the pneumothorax, even though it's one of our topic related to emergency, where we discuss about trial chest, some of the cardiac tamponade and pneumothorax again, but it again part of our respiratory though. So these are the things you need to study: types, clinical feature, investigation, management, DT, 25% rule related to management, on trial chest and in future. Most dangerous type of pneumothorax is a tension pneumothorax. Whole mediastinal shifted, apex bit shifted, trachea shifted, and you can see very clearly in the. So what you need to do in these cases is insertion of the needle in the second intercostal space. Have you guys seen a very famous nowadays TV series that The Good Doctor? I think in the first scene, I think it was it's a very dramatic actually, very dramatic actually. And one more thing which is related to rule of 25, because when you have pneumothorax, the lung shifted to opposite side and lung collapsed as well. So it depends on the percentage of collapse. Like if you see less than 25% collapse and no symptom, observe. So less than 25 and persisting symptoms. So symptomatic any cases, percentage doesn't matter. Symptomatic cases like say hyperresonant, anyhow, go for chest drain. If more than 25% collapse, but maybe not clinically presented that much, again chest drain. So percent plus symptom, you probably need chest drain. And in tension pneumothorax cases, first you release that air by inserting needle in the second intercostal space. It is given in MC exam as a needle thoracostomy. I repeat, needle thoracostomy. And this one drain in MC they wrote as a chest drain actually. So even after needle thoracostomy, you have to give chest drain actually. Type of pneumothorax, open, close, and tension pneumothorax actually. And there's another one, we call it spontaneous. Honestly, spontaneous pneumothorax is most common. Rather than traumatic, non-traumatics are more common. Okay. Here is 5 or 6 things which definitely you need to know for pneumothorax, which has been tested in AMC in past. They'll give you clinical vaguity and ask you to make a diagnosis. So reduced air entry and percussion node hyperresonant diagnosis, pneumothorax. Reduced air entry, percussion node dull, and a trauma history, road traffic accident diagnosis, hemothorax. Guys, are you following me? I hope it is, or you are having pneumothorax. Okay, at the end, I know it's tough. Okay, so both cases, reduced air entry, one case, hyperresonant, one case, it is done. Treatment of tension pneumothorax tested in MC exam, needle thoracostomy. Needle thoracostomy. Uh, Typical pneumothorax open or close. I mean, after resuscitation, chest drain, no? Chest drain. But emergency cases, needle thoracostomy. They'll give you a picture, radiology, you see, trachea, apex bit shifted. And there is lung collapsing also happens. Actually, you can see in the Google multiple radiologies. We also have a radiology album. In future, I will guide you on that one. There's a special thing came about pneumothorax. What suggestion you will give for pneumothorax? See, follow-up is also important for some diseases. Pneumothorax is one of them for MC. So, is it recommended air traveling? Your lung is already collapsed a bit. Are you recommending air traveling now? No. So, first 3 months, no air traveling. Also, underwater driving wherever pressure on the lung cannot do that. Okay. So again, the treatment less than 25%, more than 25%. This one to remember from the John Murtagh for the pneumothorax. Yes. Anything which put pressure on the lung need to be avoided. I hope pneumothorax related things are clear to you guys. Last but not the least, in tuberculosis thing, we learn a lot in our exam. I mean, but in Australia, is tuberculosis common? Quick question is in Australia, are you expecting TB cases? Very rare. So those are the like immigrants mostly. When you go to Australia, you see you have to do only one test, right? I mean, those of you already been to Australia, which one test you had to do before traveling to Australia? Isn't it the chest X-ray? Mostly they look forward if you have any active TB or something like that or not. Okay. So that's the main test actually, even for the UK, yes. To rule out tuberculosis, pulmonary tuberculosis mostly. We know about this like there will be cough for 2 weeks or 3 weeks, then there'll be sputum, hemoptysis, night sweat. These things are common, fatigue, yes. Some areas are high risk, crowded people. Okay. And we do the investigation, tuberculin test, chest X-ray, but how do we confirm the tuberculosis? How do we confirm? Yes. Yes, even for traveling, you will be traveling to Australia will also require chest X-ray. Yes. Now, how would we confirm? Confirm by sputum actually. Okay. Even you want to declare a patient TB free, that also required the sputum test eventually, right? And the treatment, I think we know already. I think I don't want to get there. It's not much tested in MC, but generally there's a 4 regimen of treatment. Initially, there is a 2 month regimen course, and then there is another 4 month regimen. Total 6 months planned for pulmonary. If it's some other like bony TB, then it's a 9 month, something like that. So rifampicin and isoniazid for the later initial 2 months, all 4 regimens like ethambutol, pyrizinamide. So check out their side effects too, actually, in case all the drugs related to TB are bit hepatotoxic. Okay, all the uh, like drug side effects are bit hepatotoxicity. Except isoniazid causes peripheral neuropathy. Rifampicin causes orange urine. I'm going fast because you know these things. Ethambutol, eye problem, and pyrazinamide, gout problem. And all of them, common problem is they affect the liver, and in some cases, SGPT and this that can be raised, right? Simple as that. Now, what is actually more important is actually latent tuberculosis. For this one, next day I will show you a recall and a chart I'm going to show you for latent TB. This is taken from the RACGP guideline actually, because is Australia should be more concerned about latent or hidden TB or should be more concerned about pulmonary tuberculosis? So I'm sure you all will be agreed. In Australia, they are more concerned about uh, any latent TB someone is carrying or any immigrant is bringing that one. So latent TB is the key here. So latent tuberculosis, as you can see, latent and active. Uh, what is the concept here? Have you ever seen your professor and your head of the department of medicine is giving some treatment thinking there is an underlying TB because test results are yet not showing it's a clear TB, but out of their experience, they are giving some treatment like artemether or isoniazid, something um, treatments, thinking that it can be a TB, and we cannot uh, keep the patient dying like this, okay, like a blind treatment of TB. So it's mostly the treatment for the latent TBs actually that you do every test. It's not coming out. So probably it's a latent tuberculosis. Now, here is a question that this kind of question can given in the exam as latent TB or can be given as active TB. There was a recall question was for 2 weeks, the person is having cough. I repeat, for 2 weeks, the person is having cough and the patient was done tuberculin test and X-ray, which is inconclusive. But the patient has 2 weeks of cough. Now, would you like to go with a latent TB treatment or some other test? Or would you like to think that this can be active TB and do sputum culture? What do you think? I repeat, the key line is a 2 weeks of cough. So I think 2 weeks of cough is enough for thinking it can be active TB. So we will pick up this category because 2 weeks cough is not a asymptomatic thing. It's actually symptomatic. So we will do sputum culture, sputum for AFB. Basically, sputum for AFB we do in this case. Is it clear, everyone? So this question can be given. You have to either choose the latent pathway or either you choose the active pathway. Okay, this is how the latent TB question I have seen, but I will show you on the Thursday class regarding that actually. And I recommend you more to go to RACGP and latent tuberculosis or just type tuberculosis. They'll take you there. And if you want to know more about this slide for personal study, because you all will be doctor in Australia, I'm very sure someday. So even if you read a little bit more about this, it'll be totally nice for all of you actually. Great guys. All right. And I think we are almost at the end. So I hope so. Most of you enjoyed the class generally. There's so many other things in the respiratory system, but these are the tested topic very commonly in MC exam. And I hope you like the style. I mean, usually disease based, and do you think it is better or just briefing? Taking long lectures are easy. Squeezing is difficult actually. Yeah. Latent TB, again, I said, my dear, it's usually all the tests you do, it's just X-ray and other, all tests would be negative in latent TB. In active TB, you need the sputum. Yes. Yeah. Yeah. So again, guys, thank you so much for attending the session. And uh, I'll end this class here. I'll be still yet with you for next 4 or 5 minutes. Now, what is the strategy here? in our courses, actually, we take 5 months course, weekly two classes. Each classes are this long, like 3 hours. Why 3 hours? Because exam is 3.5 hour. So it will be like a bodily training in a way. All right. Uh, Classes are fixed always Sunday, Thursday, and next day we upload recording. It is the same schedule as the last 10 years. So if anyone requests to change the schedule, it's not possible because from different countries, doctor actually join the session actually. Class times are like 3:30 p.m. Bangladesh, 8:30 p.m. Sydney time, Australia, depends on their time zone, and 3 p.m. India and 2:30 p.m. Pakistan time actually. And other countries you can listening, please adjust your time zone by Google. You can Google it. You will find the difference of your time zone. But considering different countries, I think this is probably the best time zone. Sometimes little late, unfortunate for Fiji and New Zealand in some cases, but we all have to work hard. Yeah, we have so many doctors from Fiji and New Zealand as well. And this time, anyone from Brazil, I'm not sure, but anyways. And as I said, many I know, I mean, from my previously past doctors, my students, they all are working. So we try to build up communities and this, that. So when you pass, also message us. We'll try to engage with one, two doctors. Those are working in Australia in future. Um, and even in that group, we have the video channel we mentioned. Even if you see some of the previous candidates, you see a lot of them are already working. If you see their profile, so many doctors, I think 500, 5,000 doctors, I think, in that group video channel we're talking about. So you can see, I mean, old ones actually. I mean, this profile shows already they're working actually, yes, because they have been there, and that's like our alumni and this, that. So I'm taking classes since last, I think it's been 10th year, and experience and up to date. Even this November, we finished so many questions we moduled, in the month of November. So many new things came. One other new update, John Murtagh, the new ninth edition, and it is absolutely important that you follow the ninth edition. I mean, guys, it's okay. We are investing already a lot of money. So one this ninth edition we can definitely buy. So initial few classes I'll try to help matching eighth and ninth together, but eventually we'll be only doing the ninth edition. So first three classes I'll be also mentioning the eighth edition page number simultaneously so that you don't have problem. And later there will be only ninth edition actually. All right. And topic wise, it's more important. These are the higher topics, but always not 100% guaranteed that new one cannot come, but mostly the topic goes and comes in between them. If anything new came up, we also post in our Shahriar's AMC guideline group. So if you just search with this group name, Shahriar's AMC guideline, so that group also has a lot of options you can use. Say, I'll guide you more on the next class that we recall. So say hashtag respiratory. If you use that word to search in that group, I'll show you how to do it on the next class, and many more things I'll tell you. So you can find so many uh, exam relevant questions since 2016 because we have been posting since then. Yeah, so and many students are posting. So you guys need to be very active in that group. Yeah, so that's the thing. And John Murtagh ninth, I mean, you need to collect hard copy. That's the main summary thing. Here, other soft copies and this that are given. John Murtagh ninth, we officially cannot post because there's so many restrictions regarding that. Uh, you can understand, we are big institutions, so ninth because it's a trendy book. Well, yeah, that's the thing. So good luck to all of you, my dears. I mean, so many admission pressure on us right now. You all will be there with time, and in next class I'll little bit guide you on the pathways of Australia. I mean, so what is coming on the next day, I will be little bit guiding on the pathway, job prospects, and also how to get job after AMC1. So I will also talk about those things. It's open class, another one, next one. And Today already we show you our class routine and some of the basic things. So weekly two classes, one mock. Friday there is an overview what to study. And please just follow up, follow up, follow up. You will be there, I believe strongly. 1,900, not a joke, very big number. As I said, every hospital I know someone from my academy working. So that is already inspiring from all of you actually. So just keep working hard, guys. I mean, you will be there actually. Uh, See, I mean, some people ask, Doctor, job prospect. Job prospect is quite good now in Australia. Some people can get job in 3 months. Some people can get job in 6 months. Some people probably take year or 2 year. Okay, that's the thing. Good question. When is mock? The mock we will take next week actually. So this Sunday and Thursday we have class, and after that the next Sunday we'll take the respiratory mock. So you have time to prepare, my dear. Yes, how to study effectively as the class progresses, we'll time to time tell you everything. So don't worry at all. Like just be with us for the first 2 weeks. Yeah, so we'll be fine actually. If you want to contact, you can reach us by Facebook would be more faster. If it about WhatsApp, so I'm sharing the hotline WhatsApp. My Me and my team also will help you. Uh, just be with us for 7, 8 months and work really hard actually. Work really, really hard. You will be there actually. There will be a separate Zoom link will be shared before the class next day on the same group actually. All right. And we'll be posting the recording, after the class. Usually we post in the next day morning actually. So it requires 12 hours to post a record properly. Thank you so much. Good night, everyone. See you on next class on respiratory recalls. Good night. Those of you are looking forward for a study partner here, I will keep it open. You can also ask here, and or next day I will be also make a post. I mean, who is looking for a study partner? This that. So I'll keep this Zoom thing open for another 10 minutes. If anyone is looking for a study partner, you can pitch here now with your WhatsApp number. Maybe you guys can send each other messages. Thank you.